Thank you for the opportunity to present. I will be discussing minimally invasive distal pancreatectomy. I'm an assistant professor of surgery at the Emory University School of Medicine. I have no financial conflicts of interest and nothing to disclose. I live in Atlanta, which is a city of roughly 6 million people, making it the ninth largest in the US. It has the busiest airport in the world, the Hartsfield-Jackson International Airport. It is the home of the CNN News Network. At 63 million gallons, it has the world's largest aquarium, with Dubai having the second largest at 2.6 million. And it is the home of one of the largest brands in the world, the Coca-Cola Company, from which my medical center was funded. And I cannot resist mentioning the Mercedes-Benz Stadium with Atlanta United. The Winship name is that of Robert Winship, the maternal grandfather of Robert Winship Woodruff, president of the Coca-Cola Company from 1923 to 1934, and remained on the board of directors until 1984, the year before his death. On one hand, it is hard to support the man who made carbonated sugar an international staple, and yet, on the philanthropic side of things, his work cannot be matched by many. I will go through an overview of guidelines, literature review comparing MIS versus open approach for distal pancreatectomies, cost-benefit ratio, some tips and tricks with my personal bias, and a couple of interesting cases. To start with guidelines, Miami International Evidence-Based Guidelines on Minimally Invasive Pancreatic Resection, especially minimally invasive distal pancreatectomy, have been mentioned below. I have particularly selected those guidelines that have grade 2B or higher recommendation from this consensus conference. For benign and low-grade malignant lesions, minimally invasive approach should be considered over open approach. This is based on evidence-based approach for shorter length of stay, reduced blood loss, and similar complication rates. Minimally invasive approach is associated with better post-operative quality of life. And for pancreatic ductal adenocarcinoma, it appears to be feasible, safe, and oncologically efficient in experienced hands, but prospective comparative studies are lacking. Now I'll review a literature on MIS versus open pancreatectomies. Central Pancreatic Consortium is a consortium comprising several academic centers that have collected their retrospective data and combined them to create an amazing, powerful database. Multi-center analysis of left pancreatectomy was performed through this consortium, where the question was asked if laparoscopic approach should become the standard. 342 patients were evaluated in this study, and there was significant benefit of laparoscopic over open approach in terms of blood loss, complication rate, and decreased length of stay. The other independent variables affecting length of stay were age less than 65 and no complications. The length of hospital stay was little over 2 days less for laparoscopic approach compared to open approach. The conclusion was that laparoscopic approach to distal pancreatectomy is preferred for management of select patients with left-sided pancreatic pathology. The strength of the study was its multi-center analysis with matched cohorts, with several centers only performing open surgery, and the weakness was its retrospective design and inability to assess quality of life. Another multi-center analysis performed through the same consortium questioned laparoscopic approach for distal pancreatectomy adenocarcinoma. Out of 1,755 distal pancreatectomies, only 13% were pancreatic ductal adenocarcinoma. Of these, 212 patients had enough data and follow-up for analysis, with 89% done open and 11% performed or attempted laparoscopically. This table shows the most important factors broken down by operation type. The only significant difference between the group was the body mass index, which was higher in the laparoscopic distal pancreatectomy group. There were no differences in the total number of nodes, the node positivity, the positive margin, or the receipt of adjuvant therapy. However, the blood loss appeared to be less in laparoscopic approach, closely approaching statistical significance at 0.08. There was no difference in cumulative survival as evident by this graph. In conclusion, laparoscopic distal pancreatectomy is an acceptable surgical approach for select patients with ductal adenocarcinoma of the left pancreas. The strength and the weaknesses remain the same as before. Here is a summary comparison of data which included at least 10 patients in each category. In order to make some sense of these, I grouped them by study type rather than by year of reporting. The only area I want you to concentrate on is the margin positivity rate appeared to be less in the minimally invasive group compared to the open group. The two comprehensive reviews, one meta-analysis published in Journal of Gastrointestinal Surgery in 2015, showed that the laparoscopic approach in treatment of pancreatic ductal adenocarcinoma appears safe and efficacious. However, the studies remain underpowered. And the Cochrane review suggested that the existing studies are not sufficient to eliminate bias. Randomized studies are needed. These were the randomized controlled trials that were attempted, and some were published. The lap versus open distal pancreatectomy and the robot versus lap distal pancreatectomy were terminated and withdrawn, showing how difficult it is to accrue patients for distal pancreatectomy with pancreatic ductal adenocarcinoma. The Leopard Trial is successfully published that I will discuss, with its primary endpoint being functional recovery. The Leopard Trial has completed accrual and has released a hint of their results, with primary outcome being length of stay. The DISPAC 2 trial is pending and the Diploma trial is currently recruiting. The Leopard trial is a randomized controlled superiority multi-center trial comparing minimally invasive versus open approach for distal pancreatectomies. It involved 14 centers. The primary endpoint was time to functional recovery, which resulted in independent mobility, adequate pain control, no IV fluid or drug administration, and maintaining greater than 50% of daily required intake. No signs of infection. The patients were blinded. In this study, the time to functional recovery was significantly less by 2 days compared to the open approach. The complication rate in terms of Clavin-Dindot classification and the 90-day mortality were similar. The post-operative pancreatic fistula rate appeared to be less in open approach compared to minimally invasive approach, and the length of stay was significantly lower in the minimally invasive approach. In conclusion, minimally invasive approach was associated with a 2-day reduction in time to functional recovery and is the treatment of choice for patients with left-sided pancreatic tumors. The LAPOP trial, again comparing minimally invasive distal pancreatectomy versus open, is a randomized controlled trial that is not blinded, conducted at a single center, with a superiority design. The primary outcome of reduced hospital stay was met with laparoscopic approach. The secondary endpoints included shorter time to functional recovery in the laparoscopic group. The conclusion was that the laparoscopic approach should be considered method of choice for low malignant and pre-malignant lesions. This is a case with a CT scan representing distal pancreatic adenocarcinoma. If a standard distal pancreatectomy is performed here, the margins would be threatened. It would probably be appropriate to perform an anterior ramps. And here, it's probably better to perform a posterior ramps for this case. These are the margins of distal pancreatectomy for pancreatic ductal adenocarcinoma, where you can see the SMV portal vein. You can see the hepatic artery. Here you can see the renal vein and the adrenal vein. This is a resection bed of an open rams, where here is the portal vein, splenic vein confluence. Here's the celiac axis, the aorta, the SMA, the left renal vein, and the left kidney. This is a similar resection bed with a robotic approach. Here's the pancreatic stump. This is the splenic vein going into the portal vein divided right at its origin. Here's the splenic artery divided right at its origin. In this case, we had to resect a part of the posterior fundus due to its adherence to the tumor. And here's the adrenal gland. This is the resection bed in the left renal vein. In comparative institutions where RAMS was performed at Washington University, the margin positivity rate was significantly lower, with an improvement in median survival. The reason why it is so difficult to perform a randomized trial is the following. The resection of left-sided pancreatic cancers is very few. Out of the total number of 46,000 cases of pancreatic ductal adenocarcinoma, only 9,200 are resected. That's 20%. Of these, only 10% are left-sided. And of these, only 27% are laparoscopically approached. A pan-European propensity score mesh analysis performed between 34 centers, 11 countries, and 1,212 patients showed significant improvement in blood loss, hospital length of stay, and margin positivity rate with minimally invasive approach. However, the Girota's fascia resection was better with open approach, and the lymph node harvest was better. However, the overall survival was not affected. This was a precursor to the randomized trial. Diploma is a randomized control trial. It's an international trial with a non-inferiority design, with the primary endpoint being margin positivity rates. The patients were blinded, not in US. RAMS is performed routinely for distal pancreatectomy for pancreatic ductal adenocarcinoma with a sample size of 258 patients. So far, 173 patients from 30 centers are randomized. We expect this to be completed in the next year or two. This is the graph showing the current enrollment for the Diploma trial. The blue line represents the current enrollment and the red line represents the expected enrollment. Because of the pandemic, the blue line is drifting slightly away from its expected rate. This is a meta-analysis of robotic versus laparoscopic distal pancreatectomy published in BMC Surgery, where there were 10 studies, 813 patients, 267 were performed robotically, and 546 were performed laparoscopically. There was a higher rate of spleen preservation and lower rate of conversion to open with robotic approach. The hospital length of stay was shorter and the cost was higher. However, in conclusion, the outcomes were more or less similar. This graph represents data of the fellow from 24 accredited HPB fellowships in 2015. And this is published in the Journal of HPB Surgery. Here you notice that still most of the distal pancreatectomies in 2015 were done open, with some centers barely performing laparoscopic and many centers not even performing robotic distal pancreatectomies. Hopefully things have changed over the course of the last 5 years. I'm going to discuss two studies regarding cost benefit. This study is a 90-day cost analysis for open versus minimally invasive approach for distal pancreatectomies conducted at University of Wisconsin between 2012 and 2014. Median costs for index operation and 90-day readmissions were recorded and analyzed. 693 patients underwent open approach, 146 laparoscopic, and 53 robotic. In the minimally invasive distal pancreatectomy group, the patients had a significantly shorter length of stay and lower payments. On multivariable analysis, there was a 90-day cost savings with minimally invasive approach relative to the open approach, and this is probably attributed to the shorter length of stay, with the laparoscopic approach allowing a 21% cost savings compared to the 25% with robotic approach in relation to the open approach. This resulted in a cost saving of approximately $8,500 to $10,000 per case with the minimally invasive approach. Another study by Maelstrom from City of Hope analyzed patients between 2011 and 2017, of which 41 were open and 39 were minimally invasive. 28 of them were performed robotically. Conversion to open pancreatectomy occurred at a 36% rate, with 11 cases converted from robotic to open. The length of stay was shorter with the minimally invasive pancreatectomy compared to minimally invasive converted to open, which was still shorter compared to open approach. The laparoscopic distal pancreatectomy was the least expensive, whereas the robotic converted to open had the highest operative room cost. However, despite the highest operating room cost, the total cost was similar for robotic distal pancreatectomies converted to open compared to the open approach, probably likely due to the length of stay. In conclusion, financial consideration should not play a role in selecting robotic or open approach. The open approach had a 10-day length of stay for the study. Now I'm going to discuss some tips and tricks with my personal bias. In regards to pancreatic stump closure, especially with minimally invasive technique, I use white load stapler and I routinely use seam guard based on the randomized control trial published by Washington University that showed significantly decreased rate of fistula formation. That's the only randomized trial showing staple closure with and without buttress. In my mind, it is a no-brainer to use phalansteal incision for specimen extraction. The rate of hernia and wound infection is significantly low. The reported rate of hernia through a phalansteal incision is 0 to 0.5% compared to up to 20% with any midline incision. Physiologically, it makes sense for me to leave drains more so for distal pancreatectomies than for Whipple's, as the ampulla is preserved in distal pancreatectomy, increasing the pressure in the pancreatic duct. A word of caution for young faculty, trainees, and even senior faculty members that it is much easier to divide than you think or ligate the common hepatic artery by confusing it to be the splenic artery in minimally invasive cases. I would be very careful and trace the artery towards the body of the pancreas before dividing it. I'm going to discuss a couple of interesting cases now. This is a case of a large mucinous neoplasm in a young patient in the early 20s. It is not clearly depicted here, but here you can see that the pancreas is wrapped around this cyst, depicting the classic mucinous neoplasm which is nested within the pancreas. This case was performed laparoscopically because I did not have access to robot on that particular day. And it was removed through a phalangeal incision. This is roughly about 10 centimeters and small incisions. The final pathologic diagnosis was mucinous cystic neoplasm. No invasive adenocarcinoma was identified. The patient was discharged on postoperative day 3 and recovered uneventfully. No follow-up was required. This is a case of a 76-year-old gentleman with pancreatic neck cancer 3 months after gemcitabine Abraxane. This scan reveals the pre-chemo time period when the pancreatic cancer is seen out here. And here you can see the post-chemo time period. Concentrate on these areas to see the benefit of chemo in this particular case. This was resected via ramps. No residual cancer was identified and 36 benign lymph nodes. The patient discharged on postoperative day number 3 and recovered uneventfully. In conclusion, laparoscopic approach or robotic approach is an acceptable standard approach to distal pancreatectomy. More so than laparoscopic pancreaticoduodenectomies, laparoscopic distal pancreatectomy is available to competent pancreatic surgeon with reasonable minimally invasive surgical skills. Thank you.